Hi everyone, my name is Parshva Salvi. I'm a fourth year medical student at Wayne State University, and here I'm presenting a cool case that I saw during my interventional radiology rotation. We have a 47-year-old male who presented to the hospital with worsening productive cough, sore throat, and shortness of breath for the past 6 months. He also complained of cough that gets worse with eating and also endorsed new onset facial and neck swelling. He also noted a new presence of blue markings on his ribs. In terms of his review of symptoms, he denied any weight loss, fever, chills, or fatigues. He did have rhinorrhea and sore throat, but didn't have any sinus tenderness. He did have cough and shortness of breath, but otherwise the rest of the review of symptoms was unremarkable. His past medical history is significant for basal cell carcinoma of the back, obstructive sleep apnea, rosacea, and irregular heartbeat. He has had a vasectomy and a surgical excision of a BCC in the past. His medications include topical metronidazole and tadalafil. Allergies include minocycline, and family history is significant for colon cancer in the father who died at 48, and lung cancer in grandmother and grandfather. Social history is significant for 3 drinks per week, but denies smoking or illicit drug use. On presentation, he was hemodynamically stable. He was normotensive, normal heart rate, normal temperature, and SpO2 of 96%. For his labs, his CBC was normal and BMP was normal except for sodium of 132. On physical exam, he had posterior oropharyngeal erythema and presence of varicose veins on the chest. Otherwise, lungs were clear to auscultation bilaterally, and he had normal heart sounds. So based on the information so far, here's a list of the differential diagnoses. First on my list is a mediastinal mass with SVC syndrome. This would explain the cough, the shortness of breath, the sore throat, and the possible paraneoplastic SIDH given his low sodium. This would also explain the SVC obstruction signs that this patient had, such as the neck and the facial swelling and the venous markings on the chest. The second on my list is esophageal carcinoma that can cause cough that is worsened by eating and sore throat as well. Mediastinal invasion of the esophageal cancer can lead to SVC syndrome, but this patient does not have any dysphagia, no weight loss, and the patient does not smoke, so it's second on my differential. Third on my list is tuberculosis that can cause chronic cough, sore throat, and it can also cause mediastinal lymphadenopathy leading to SVC syndrome symptoms. But it is less likely given the normal labs and no constitutional symptoms seen in this patient. Fourth on my list is chronic sinusitis that explains the sore throat, rhinorrhea, and cough, but it does not explain the venous marking on his chest or the neck or the facial swelling. Also, the patient did not have any nasal congestion or sinus tenderness. And the last on my list is severe GERD. This fits with the patient's presentation of cough with eating, chronic cough, sore throat, and posterior pharyngeal erythema as well. But this would not explain the SVC obstruction symptoms or the venous markings that are seen on the patient's chest. And he also did not complain of any heartburn. Given the patient's presentation, a chest X-ray was done that showed soft tissue prominence in the right hilum, measuring about 7.5 by 4.2 centimeters, concerning for mass or lymphadenopathy. To further characterize the soft tissue prominence seen on chest X-ray, a CT chest with contrast was done that showed heterogeneous, partially calcified mass within the anterior mediastinum, measuring 10.3 by 7.5 by 9.1 centimeters, with encasement of the superior vena cava, resulting in significant narrowing of the SVC. Given the presence of mass in the anterior mediastinum, a CT-guided biopsy was done by interventional radiology and was sent for pathology that showed results significant for thymic carcinoma. Just a quick sidebar on the anterior mediastinal masses. They can be remembered by the mnemonic 4 T's. The first T stands for thymic tumors. It can be either a thymoma, which is benign, or a thymic carcinoma, which is malignant. Second T stands for teratoma, which is a germ cell tumor, and it can contain fat and calcifications. Third T stands for terrible lymphoma, which is often seen in younger patients, and they have B symptoms, and it is a homogeneous mass. The fourth T stands for thyroid. It can either be a substernal or an ectopic thyroid. It can have continuity with the thyroid, or it can be a thyroid carcinoma. In terms of epidemiology of thymic carcinoma, it is a rare aggressive epithelial malignancy of the anterior mediastinum, and approximately 0.4 to 0.5 cases per million annually are seen, with mean age of diagnosis in the 6th decade. For histology, it demonstrates a malignant epithelial cells with marked nuclear atypia, increased mitotic activity, necrosis, and a desmoplastic stroma. It can be differentiated from thymomas by the absence of immature T lymphocytes. For the diagnosis of thymic carcinoma, you rely on the clinical features of cough, shortness of breath, and SVC compression symptoms. You also order tumor markers such as AFP and beta HCG to rule out germ cell tumors. TSH, T3, and T4 are also used to exclude ectopic thyroid tissue. CYFRA21-1 is a tumor marker that is often elevated in thymic carcinoma. You also need to get imaging, such as CT scan with contrast, which will show lobulated infiltrative anterior mass with necrosis or calcification. And you can also get a PET-CT, which will show high FDG uptake, which is helpful for staging. For the definitive diagnosis of thymic carcinoma, you need a biopsy with either a CT-guided core biopsy or mediastinoscopy. In terms of management, if the mass is resectable and non-metastatic, complete surgical excision with open thymectomy and mediastinal nodal dissection can be done with adjuvant radiation. If the mass is unresectable or if it's locally advanced or metastatic, then a platinum-based chemotherapy is the first line, with or without concurrent radiotherapy. Prognosis is usually poor compared to thymoma, with a 5-year survival rate of 30 to 50% due to frequent advanced stage presentation and higher rates of recurrence and metastasis. Here's the list of all the references. And that's all I have here. Thank you for listening. I hope you enjoyed it.